My name's Amber Guyette. I'm the Behavioral Health Account Specialist at Alliance for Better Health. And I'm happy to welcome everyone to the Primary Care and Behavioral Health Provider Breakout session, titled Innovative VBP Contracting to Drive Value and Performance. So we have three speakers today that will be speaking to you on this topic. Our first, and to my direct right, is Bob Edmonson. He has more than 25 years of experience in driving healthcare strategy for physicians, hospitals, health systems, and payers. He is currently Vice President of Provider Strategy for Beacon Health Options, a behavioral health management company focused on improving the lives of those with mental health and substance use challenges. A pioneer in population health management, Bob was instrumental in developing early accountable care organizations, or ACOs as we know them. At Beacon, he is responsible for implementing value-based payments for behavioral health professionals across New York and the Mid-Atlantic region. The next speaker, right in the middle, is, Shelbi. Yeah, we switched it on my page. So we have Shelbi DuBord. MPA is a regional performing unit lead at Care Compass Network with a background in nonprofit leadership, grant writing, strategic planning, emergency management, marketing communications, and volunteer management. Prior to working at Care Compass Network, Shelbi has the Director of Community Initiatives and Planning with United Way of Broome County and the Executive Director of Broome County Community Organizations Active in Disaster. Currently, Shelbi leads a team of network facilitators to cultivate network of care around cohorts of Medicaid members through Care Compass Network's Cohort Management Program. And then last but not least on the end is Emily Page, PhD. She's the Director of Population Health at Care Compass Network and has a background in healthy care policy, health services research, and health informatics. She holds a PhD from the University of Michigan School of Public Health and a master's in economics. Emily's team at CCN is responsible for supporting the PPS with analytics and data warehousing, managing a performance incentive program for CCN partners, and overseeing a program for innovative pilots to improve DSRIP performance metrics results. Emily is a lead designer of the Cohort Management Program and is developing population health analytics services and tools for CCN partners outside of DSRIP and helping to cultivate evidence-based approaches to improve patient outcomes. Please hold all your questions until after the presentation. We have a pretty lengthy room of time for Q&A. And that being said, I'll hand it over to Bob.
Thank you. So how many behavioral health providers do we have? Keep your hands up, keep your hands up. How many of you have active VBP programs? Aha, there are a couple, right? You're wavering a little bit, huh? Pilot programs, right. So behavioral health, we're way behind medical health. We're not even close. And there's a lot of reasons. You heard those reasons earlier from the other speaker, but we're just ramping it up now. So I'm talking about implementing it in New York, because we don't have it in New York. I was asked to bring a provider with me that we have partnered with, and I don't have one yet, okay? We're just starting to roll it out. What I'm going to describe to you later in the presentation is our sort of first foray into VBP here, and it's just to level 1 shared savings upside only model. And we haven't even done it yet, so we're just getting started. We're just ramping up. But what I want to lay out is how we would do that from a behavioral health perspective. You heard earlier he was talking about what do you measure, how do you measure that, how do you do the shared savings calculations. I'm going to get into that a little bit. But before I do, I'm going to talk about what I'm going to talk about. I'm going to just go over value-based payments briefly. As you heard in my introduction, I've been doing this a long time, since at least 2011, mostly with Medicare programs and ACOs. I'm going to just briefly touch on a couple things in New York State. I've been in this job for 6 months. It's the first time I've been on the behavioral health side, and I've worked in New York off and on. So you out there in this room know a lot more about the regulations and the state and DOH and OMH and OACs than I do. But I'm just going to touch on a couple of programs that are out there that we might have some interest for us. Then I'm going to talk about our models that we have at Beacon Health for VBP, the one that we're going to be implementing, and some out in the future potentially, and then talk about the future of VBP. So just very briefly, value-based payments, the objectives. Everybody knows this, but I just want to touch on the things that we're looking for in behavioral health, because we're looking for some very specific things. One, obviously improve quality and outcomes. Two, empower the providers and the community organizations, the CBOs, the HCBSs, because the idea here, obviously, is to take, my company is essentially a payer, right? So what we do is we're a vendor for some of the major payers in New York State, and we manage the behavioral health side. So the idea behind VBP is really take the utilization management, the care management, all that stuff that manages the care, and put it on the providers. We don't have a lot of that in behavioral health right now, very little, but that's what our concept is. Yeah. Oh, sorry about that. Okay, so you got me already. I'm not moving my slides. I got two. This one is not linked up with that one, so I was moving the slides, and you guys weren't seeing it. Thank you. So improve quality outcomes, empower providers and community organizations, reduce overall spend. And I think one thing that we're all interested in as we move into the post-district world or the next phase of district world is how do we generate new revenue streams? How do we move from the fee-for-service, the volume-based, just doing more and more and getting paid more and more, to saying, what are some new revenue streams that we can generate based on outcomes and based on value? Okay, so this is sort of a snapshot history of all the programs, a lot of them driven out of CMS and a lot of them around Medicare. The only ones that I want to point to are the Medicare Shared Savings Program, the ACOs, and the bundled payments, because that's sort of where we're hitting the ground running, I see, here in New York. Just with the concepts behind VBP, obviously the concept is to move from a transactional thing where we're going from treatments and certain types of very episodic, narrow episodic episodes of care to more longitudinal, over time, improving health, and that's a very important in behavioral health. From volume to outcomes, from individual based, just focused on individual patient base, to more population based, and I'll be interested to hear about the population health management stuff that Emily's doing. Obviously, fee-for-service to fee-for-service plus increased risk for the providers, rising spend to cost savings, payer-driven utilization management to provider-driven utilization management. I had one of my care management people come to me last week, and she said, you know what, you really got to get this VBP program implemented. And I said, why? She said, I think I've done all I can in terms of utilization management with the providers. Now they need to start doing it. They need to start picking it up. And I think we heard before there were some issues about the providers, the buy-in from some of the providers, especially in behavioral health, to start doing this and managing this stuff themselves. And then finally, what we talk a lot about is just basic clinical services and adding on, I think, what's very important, and we're going to hear a lot more about that in the second half, the social determinants of health. Okay, just real briefly, what we're looking for at Beacon to do with our partners, and we're a national company, so essentially what we want to do with our providers is really empower them and give them the tools and the funds and the ability to do some really interesting, innovative stuff like telehealth, like patient engagement and care coordination functions. I think the providers want to start doing this, but they need the ability and the freedom to do that. And then enable them to treat patients holistically and provide the whole continuum of care. For our members, we think it's better person-centered care. It's care that's fit to their specific needs, and they can have access to more innovative programs. And again, for us, what we're looking for is to align the compensation of the providers with the quality outcomes that we're trying to achieve. And I'll talk a lot about that in a couple minutes. And then what I mentioned before is this whole shift in utilization management from having the payers push down and do the UM to having the providers and their partners manage that more effectively. Okay, but we have challenges on the behavioral health side, okay? And here's a little bit of a contrast of the medical versus the behavioral, all right? One, all the money's in medical. We're just a sliver, right? So the savings that we can generate just from our spend is minimal. However, what I know everybody in this room knows is that behavioral health has a tremendous impact on medical. But if we're just looking at a value-based savings program just with our behavioral health spend, we're starting with a very small universe. And I'll talk a little bit about some ideas in the future for us to address that. On the medical side, they've been organized into these large ACOs and IPAs and health systems and physician groups. On the behavioral side, you still see a lot of very small groups, individual providers. You see a lot of small rehab facilities and hospitals. It's not until now that we're starting to see them come together in some of these more organized arrangements, such as the behavioral health care collaboratives. Attribution. I'm going to talk a lot about attribution because this is a big challenge for us. So attribution, the way they did attribution in ACO with the MSSP is through the primary care physician, right? Patients that were in the pool of the primary care physician were assigned to that PCP, and that group of PCPs then were on the hook for managing the spend and getting the shared savings. How do you do that just in behavioral health, right? There's no such thing as like a behavioral health PCP that's sort of the quarterback managing all the care. So that's a challenge for us. Medical's been doing it a long time. There's a history of success. I know that you've achieved a lot of success in doing that. Again, behavioral, we have almost no history in this. When I came over to the behavioral health side, I was really surprised that the payments are still per diems. I was shocked by that we're still doing per diems. And finally, medical, more short-term episodes of care. Behavioral health is usually very long-term episodes of care over time. So our challenges, attribution methodology. So for a shared savings model, you've got to find a population of patients or members, as we call them, right, that you identify and you say, okay, this population of members is associated with this provider, and that provider is managing the spend for that population. So the question is, how do you do that? How do you do that attribution? And I'll tell you a couple ideas in a minute. The complexity and the number of state programs, there's a lot of competing state programs on the behavioral health side, the HARP and all these other programs. And this question, I think, that we need to start asking ourselves is, how do we fit with these other programs? Because if you have ACOs, right, and you have the total spend in the ACOs, you want that behavioral health influence to manage that total spend. So we have a couple models in other states where we do things like a subcap. If there's a capitated population, we'll sub out just the behavioral health piece, but it's just a piece that is part of the whole. So we need to think of some creative ideas about how we work with the medical spend, because again, that's where the dollars are. Scale of spend in behavioral health versus medical, I mentioned. Achieving critical mass of members. Any value-based program, you need lots and lots of members for the numbers. Participating in savings from total spend, I mentioned. And this whole concept of integrated care in New York and where that is going and how that's going to play out. We're still not sure. Okay, just a couple of things on New York VBP. I like this slide because, again, I just found this, I got this off the website of the state, but I mean, 21% of the population has with a mental health disorder, but 60% of the Medicaid expenditures, over half of hospital admissions, over 45% of ED visits. I'm shocked at, you probably already know this, but this population, their ED utilization is unbelievable. It's so high. 82% of all readmissions. So obviously, behavioral health is going to be a big part of any solution that we come up with. Okay, key elements of New York VBP. And this, again, this is my take from sort of being an outsider, only being here 6 months. You've had this program, you had the district program, you had some success, so you're not new to it. It seems to me that a lot of you have started to put together the infrastructure, the care management, the data reporting requirements in order to be successful. So, my take is we're sort of there, but now what? How the payment's going to happen and how are we going to get VBP in behavioral health? We lag behind medical. There are some targeted populations that are carved out, for example, the HARP population, the developmentally disabled, which was a presentation you heard earlier. MCOs and providers are allowed to structure VBP arrangements with generally pretty broad guidelines. And the piece that I really like about this is, which is why we sort of have this meeting, is that the state understands that these community-based organizations, they've got to be a part of the solution. And it's really important that they've built that in to the model. So that's actually a very good thing. Okay, this is a slide everybody's seen, and everybody knows about this, right? The metrics for when we need to get to a certain amount of spend with VBP. So this is what I'll say, is that I told you we're just starting off level 1. I know a lot of you are probably at level 2 when it comes to the medical spend, right? But we're just at level 1 and just starting level 1. Again, our numbers aren't that big, so it's not really hurting the MCOs in terms of making these targets, but we're just starting out and we're just catching up. So I think what our plan is to start off with a level 1 VBP this year, and then in 2020 really move to levels 2 and 3 potentially. Okay, quickly about the HARP, the whole HARP program with the health homes and the home and community-based services. This entire infrastructure that New York State has put together is a great opportunity, because you know what problem that solves for us? It solves the attribution problem, right? Because these are fully capitated, cared for populations, and there's a good infrastructure there for population health management. The risk is already built into the reimbursement. So this is an opportunity for us now on the behavioral health side to get our patients, because the HARP patients, as you know, are patients that have been, their primary diagnosis is a serious mental illness. So this is an opportunity for us to start partnering with the medical side of the house on total healthcare spend and manage that down. And I'll describe that program to you in a couple of minutes. Okay, behavioral healthcare collaboratives. How many of you are a part of one of these? Probably a little bit more, right? Okay. So obviously the state thought, you know what, we have got to get these providers together. So they put their money where their mouth was, and they invested a lot of dollars to help you all organize into the BHCCs. With the idea being, and this is something that I'm still working out, and I would actually like to get input from people at some point, is that they'll be up and ready to be participating in VBP arrangements. Now, the question that I think is still out there is who are we going to contract with, right? Are we going to contract with the BHCCs that are forming IPAs? Are we going to contract with providers within the BHCCs? I still think that's a question, and we can discuss that if you'd like. So I'm just going to sort of skip down. We all know who's in BHCCs, providers, community-based organizations, et cetera, PPSs. The goals of BHCC, whoops, I didn't move my slide. The goals of BHCC are to ensure providers measure and achieve clinical quality outcomes, develop the provider's capacity to show value and track quality, develop the infrastructure to sort data collection, reporting, and analytics, et cetera. So the idea here is that the BHCCs are going to put together these competencies that are needed for VBP in terms of demonstrating value and measuring everything. A couple of examples, I guess, of early successes in behavioral health with BHCC partnerships and contracting partners. Here's one where a BHCC partnered with an FQHC and created a joint IPA. Here's a substance use disorder specialty BHCC with a special needs plan. That's the HIV/AIDS plan. Again, that's a fully at-risk model. And then you see a couple other ones with hospitals and district, et cetera. So they're definitely starting to get some traction. So we're looking at doing value-based payment partnerships in New York, and we're ready to go with this model I'm going to show you in a minute. So my question is, and I haven't answered this yet, right? Who do we contract with? Do we contract with the providers and then have the providers subcontract or have some sort of a relationship with the community-based organizations and all these other SDH types of organizations? Or is it going to make more sense for the MCO to directly contract with providers and CBOs? Or, and the other one I didn't put up here is, do we contract with the IPAs, which the BHCCs are? So right now, as we're moving into this, we're open for whatever happens. The first phase of what we're doing is we're just going to be partnering with providers. And that's just for this first phase. That's not to say, I actually have a couple meetings set up with a couple of the BHCCs to see how we could collaborate and what some of their thoughts are. But right now, we're going to go straight to the providers. And one reason we're doing that is I'll show you when I go through the criteria for selecting providers. Okay, so building value-based payment for behavioral health. So we have very specific objectives for what we want to accomplish when we're looking at value and outcomes, okay? One, the handoff. The handoff between an inpatient care episode, whether that's a mental health episode or a detox, and that handoff and that relationship to the outpatient setting. Because that is the key to success, right? If these patients do not have that continuity over time on the outpatient side, and they go back to their situation, that's where we get the recidivism, that's where we get the readmissions, that's poor quality care, okay? So that's one thing we're trying to accomplish. Second, connect patients with outpatient treatment modalities. So we want to move away from just responding to post-inpatient to setting up patients with outpatient services. Reduce ED visits and readmissions, same as medical, right? Same exact thing. Now, one thing we're very interested in at Beacon, and we're very committed to this, is one of our major things has to do with substance use disorder and opioid use disorder. So we're very interested in encouraging providers to use medication-assisted treatment, or MAT, which essentially is where you start to get patients, especially right when they're in the inpatient setting, you start them on one of these medications that helps them deal with their cravings and their urges. The most common one these days is buprenorphine. You probably know the Suboxone is the brand name. So this surprises me how few providers do this, because the evidence here says that the evidence is clear. This is how we should be treating people. We're moving from a just purely, we're moving to a model that treats substance use disorder as a medical issue that needs to be dealt with in a medical way, i.e. through pharmaceuticals and therapy, a combination of both. So we're very interested in seeing our providers do that. So that's something we want to incentivize them to. We want to engage and empower providers to take a broader role in utilization management, as I talked about before, and we want to move away from volume-based to incentive value-based. So one of my jobs I have at Beacon is I'm the contracting guy, okay? And so right now I have 232 requests from providers to raise their rates, right? They want their rates raised. Who doesn't, right? Their rates are here, they should be higher, they want their rates raised. What I want to do, my objective is to say, let's get away from this rate discussion, right? Let's not have the rate discussion that, you know, you get this rate from this payer and this rate from this payer, and you should get the same rate, and Medicaid is this, and Medicare is that. Let's take these dollars and the potential dollars that we can take out of the system through shared savings, and I want those to be your new incentives. And that's a new discussion for behavioral health. That's a brand new discussion. They're still on the fees. That's it, fee for service. Give me more money. So if we can achieve that over the next few years, that's going to be pretty dramatic. Okay, just to show you that I told you we're a national company, so here's a couple of models that we have across the country. You know, California, we have a case management model. We have a couple of sub-cap models, one in Colorado, one in Florida, and also in New Hampshire and Massachusetts. We have an opioid case bundled program. So we're just dipping our toe in. You can see a lot of the other states aren't as advanced in behavioral health either, so we're not alone. Okay, so our programs are based sort of on four major categories of programs. One is pay for performance. That's something we've been doing, right? That's your basic, we'll just give you an additional payment and incentive payments if you do the things we want you to do. Then there's a shared savings, which is where we're going now. Then there's case rates. Case rates could almost be like bundled payment rates, in saying that if there's a certain case, like say for example a detox treatment episode, we'll give you one case rate. But if we give you that case rate, there's a lot of utilization measures underneath that to show that you're utilizing it enough, not less. And And of course, quality targets are built into everything. Every single program that we have, there's a threshold quality target that you have to hit before you can get payments. And then finally, a program that we're starting to roll out here in New York in conjunction with the HARP program, and that's total health, where we're going to start to look at generating shared savings for total health spend. So let's just start pay for performance. Here's a model of a pay for performance that we do. I told you that MAT's very important to us. So we set up incentives for, I think this is one that we actually do in Washington, D.C. But I mean, we set up incentives for our providers to do what we want them to do, which is provide education about MAT, to start the MAT at the inpatient stay, next day follow-up, and then we look at 30-day readmission rates and 90-day readmission rates. This is your very basic P for P. We set up targets. If they get the targets, then they get the incentives. But this is where we're moving now, is to the value-based payment system. So this is how we're setting it up, okay? So the first thing, select the right providers. Who are the right providers? This is the criteria that we use. You got to have a critical mass of providers. When we look at our claims payment run and who the providers are that we work with, you do go from some that, especially the large systems, I'm thinking of large systems around the city that have thousands of patients, and then that long tail where you've got very, very small numbers. So there's got to be a critical mass of patients. Maybe this is something the BHCCs is going to help with, right? Is to put the providers and some of their affiliates together to then create that critical mass. We'll see if that happens. Appropriate clinical service configuration to do what we need them to do. A collaborative history. Is it somebody that we've worked with before? Is it somebody that we've collaborated with on initiatives before? Claims accuracy, very, very important, okay? I know there's been a lot of talk about data, but when we do our value-based payments, we're going to base it on what we got, our data, and our data is our claims data, right? So it's got to be accurate, right? So we got to make sure that this is a provider who is submitting claims, they're submitting them accurately, they're going through, and everything's working. We have thresholds like 60, 70, 80%. So that's very important to us, because if that claims data is not there, this program's not going to work, and all we're going to do is argue about the numbers, right? We don't want that to happen. And then finally, we have this debate internally all the time. What providers do you think you should get? Should you get the high-performing, good utilizers, high-quality providers? Or maybe should you sort of get the C and D students, right? The ones who sort of need a little help, a little assistance. The answer is we do a blend of both. I sort of like the ones that could really demonstrate improvement. Those are the ones that I like to target. Okay, then my favorite topic, attribution. How do we do attribution? So here's what we came up with so far. I don't think it's as sophisticated as I'd like, but here's what we came up with. Our first rollout, we're rolling this out actually next month in New York. Our first rollout for attribution is an inpatient stay. So if a patient goes to an inpatient facility, then we're going to say, and we have a value-based payment contract with that provider, that patient will then be attributed to that provider for the inpatient stay and for up to 90 days past the inpatient stay. So it's sort of an episode, it's sort of a blend. So that's how we're going to initially do the attribution. What we need to get to is outpatient, because ideally, I don't know if there's a lot of hospital people in here, but ideally the idea is they never go to the hospital, right? They never go to the ED, right? They go to some of this innovative stuff that you guys are doing, like these freestanding crisis centers, or that living room thing that we saw, or all these other alternatives. But those exist on the outpatient side. So we're going to struggle with how we do an attribution. Right now, what I think we're looking at doing is to say, if an outpatient provider is saying maybe 2 or 3 times in a year, then we can safely sort of attribute that patient to that provider, because as you know, in these episodes of care, you don't go just 1 or 2 or 3 times. There's multiple visits. So that's something that we're potentially looking at for attribution. And then episode of care in a bundle payment is another way to do it. And then, of course, the HARP is the easiest, right? We already know who those people are. You know, the problem with HARP is there's not that many of them, right? There's only, I think, 130,000 in the entire state. So if you spread that out, it's hard to get a real critical mass of HARP patients. Okay, then we come up with our gateway measures. What are the gateway measures? They could be quality measures, right? They could be HEDIS measures, core measures. They could be follow-up after hospitalization. They could be readmissions. They could be MAT initiation or outpatient follow-up visits. So whatever we want to put in there, these are the metrics. And then finally, the shared savings distribution. And there's two ways you can do a shared savings distribution. You can just do a flat one. You get 50% of all the savings after against a certain target. But what we do is we tier it, okay? We tier it based upon these quality metrics, and I'll show you how we set that up in a minute. Okay, so here's an example of a shared savings program that we're going to roll out. This is mental health illness. So this is an inpatient stay generates this, right? So what are we measuring? We're measuring follow-up after hospitalization for mental illness for 7 days, for 30 days, and then we're going to measure on the bottom left, you see 7, 30, 60, 90-day readmission rates. So we'll set up targets for all these. You see targets on the right-hand side, and depending on the thresholds they hit, they can get a certain percent of the shared savings, okay? So we like to tier it to say it's not just a flat 78%, but if you get this target, you get this much money. If you get this target, you get this much money. Here, the next one. So this is one that we're excited about because this is detox, which is what a lot of our patients, oops, I need to go back, I'm sorry. This is detox, which what a lot of our patients are. So again, readmissions. So we look at no admissions for any 24 site of service for 30, 60, 90 days, where substance use disorder is the main diagnosis. And then we look at follow-up after hospitalization, again, the visits, 7 and 30 days. And then we also add into this one reductions to the ED for SUD and overdose. So the key here is that those of you who are in these programs know is to prevent recidivism and overdose. So we base those gateway targets on those metrics. So here's what it looks like. And this is a model. I think this is based on, we took it from a hospital that had real numbers. So I think these numbers might be real. But you see, so we had 738 detox partnership. Average cost per detox stay, 1987. So decreased membership admitting. In other words, this is how fewer readmissions they had within those time frames, 279. So that there is the attributed savings number, 50% eligible to provider, $277,000. As you can see, we have the measures that I talked about before, MAT indication, methadone, readmits, where they get additional bonuses if they hit those targets. And you can see the results up there. The 30-day readmission rates went from 48% to 30%, and the 90-day rates from 56 to 37%. This is a pretty straightforward model because, again, on these things you go where the money is, right? Where's the money? The money's in the inpatient admissions, especially to these large medical centers, especially in New York City, which will remain nameless for right now. But that's where you initially go. That's where the money initially is the decreased readmissions. And what we'd like to see, again, getting back to outpatient, is decreased admissions, period. Okay? So that's our model. It's just upside savings. There's no downside risk. So it's level one. It's not that complicated. It's just sort of getting started, but it's what we're doing now. I'm just going to go through a couple other models because we probably won't get to these for a while in New York. But case rates are essentially where you come up with a single payment for an entire case or episode of care. Again, it could be a detox and rehab put together. They must submit claims to show that they're actually meeting. So this is where utilization is sort of flipped on its head. Instead of trying to decrease utilization, you want to make sure if they're given a fixed payment, they're seeing these patients enough, right? So that they're actually seeing these patients on a regular basis and tracking them, okay? Or we could have inpatient case rates. This sort of demonstrates, I know you can't read this, but this sort of demonstrates how we set up a case rate. And I'm not going to go through this in too much detail, but essentially what we do is we look at the spend, we look at some comps, then we pay them at that case rate. If they come in below the case rate, they save all the money. So this isn't a shared savings model, this is a total savings model. And then again, we put in our incentives, always put in our incentives, and highly incentivize them to meet those things. Finally, total health, cost of care. This is very exciting for us. This is something that we've been doing actually up here, upstate, with the HARP population. So as you know, HARP, there's a fixed monthly payment from the state for these HARP patients, right? So that includes medical, behavioral, and pharmaceutical, and it qualifies as a level 2 VBP because there's up and downside risk. Just briefly, what happens here is that Beacon partners with a health plan. We identify these HARP members, and then we set a target. And then what happens is, on the left side of this chart, that's what we do in terms of our care management for the HARP patients. On the right side, that's the medical side. So we partner with the medical providers. There's a psych nurse that's sort of in the middle, managing and coordinating all of that care. And then what happens, and this is where it gets a little funky, is that then we've got to sort of hand it off and transition it to the health homes, because of course the health homes are a critical part of the HARP. So we don't actually manage the health homes, we just sort of coordinate and review those services. But this is a potential for us on the behavioral health side to impact the total spend for this population and actually see potentially a little bit more upside. I just want to put this up here. These are the home and community-based services that are part of the HARP program, and these are pretty strictly laid out by the state, and they all have to get the licensure and accreditation. And this just shows, so we engage and we actually pay these partners. We are not on a shared savings model with them yet, but that's not to say that we couldn't potentially get there if that would make sense in the future. And I just want, and the performance measures, we have sort of different performance measures in addition to just antidepressant medication and behavioral health. We also have things like diabetes screenings for certain types of disease categories. So it blends both the medical and the behavioral health. So that's it. So what's next for New York in the future? As I mentioned several times, we are very, very anxious to move to the outpatient setting. We are looking at broader potential VBP partners. I said that right now we're just doing with providers, but that's not to say that we're not looking at other organizations, maybe some like that are in this room right now, that it would make sense. The key is going to be, how do we identify those patients? How do we do the attribution? How do we get the data? Because if you're not an organization that generates claims for us, then we're not going to have claims data, and it's going to be much tougher for us to measure. So we're going to have to work together to figure out how we can potentially do those measurements. Collaborate more closely with medical and primary care. Obviously social determinants, which you're going to hear about in a minute. And then, encouraging the shared savings models. When we're doing these shared savings models, like I said, we want to move to something where it's a revenue that benefits everybody, right? So when we're doing these distribution models of the shared savings, we want to make sure that everybody's sharing in it and there's some upside for everybody, okay? So that's my talk. I think we're going to do questions at the end, I think, right? Okay. Then I'm going to turn it over to my colleagues. And you're going to talk about, what are you going to talk about?
I'm Emily Pape. I'm from Care Compass Network. Shelbi DuBord is with me as well. If you don't know Care Compass Network, we are PPS in central New York, so I'll show you a map. And we are really here to talk about our cohort management program and really present to you the partner experience. So we'll tell you about the program itself. Let's see. There we go. We'll talk to you about the program itself, and then I think that the takeaway for you is really about how our partners are operating under their program and some of the lessons that the partners have learned and that we've learned so far in the program. All right. So Care Compass Network, we are organized as a 501c6 PPS. We are one of the kind of NewCo PPSs. We're anchored by 5 health systems, which include a hospital at its center and then a primary care network around that. There are 5 of them in our area, as well as 1 FQHC. So we have a wealth of medical resources in our community, and then we also have about 80 pretty highly engaged community-based organizations that participate in our district programs, and are in the set of them are in the cohort management program as well. So the cohort management program is really our capstone 2AI project. We've been doing the district projects, kind of living the district dream, and then we wanted more. So we built the cohort management project really as a way to implement an integrated delivery system. So we're kind of under that 2AI district project, but we're thinking about how our partners come together and really put all the infrastructure that we've invested in into place. So it's really operationalizing that integrated delivery system into practice across all of our partners, not just the medical side, but also the CBO side. All right, so under this program, partners form networks. They integrate services specifically around a specific population cohort that they've identified. The networks have to align with the district goals, but really it's up to them to identify an organizational or perhaps personal goal and priority population. The partners integrate services around that population cohort, and we as a PPS are incentivizing improved health outcomes within that population. So the program itself divides itself into a planning phase and an active management phase. And we'll also talk about activities that either occur at the partner level, which are kind of the straightforward patient services, or at the network level. So we'll kind of toggle between those types of phases and activities. Is anyone familiar with this model? This is the health impact pyramid. Has anyone seen this before? This is a framework that really just, it reminds us how important it is to address the social determinants of health. So at the bottom level of the pyramid, we have socioeconomic factors that can impact health, of course. And I think that, being in district, we kind of know that evidence. As we move up the pyramid, we have increasingly focused services on individuals. So I think probably most people in this room work for organizations that are operating at the top of that pyramid. So providing medical care, providing mental health or substance abuse treatment services or recovery services. So you're very focused on the individual. But of course we know that those services can be very effective, but they're going to be even more effective when patients or clients are in a healthy environment. They have tools and resources available to them to really help enable those health services have a larger impact. So that's why we need to address the social determinants. So under these, the kind of bottom three layers of the pyramid, we're addressing health literacy skills, developing self-management and coping skills, providing prevention, long-lasting prevention. We're also addressing food insecurity, providing material support, supporting families and communities, and then providing transportation assistance. These are really just examples of the things that everyone in the health sphere is doing today. And it's important that as we interact with patients, we are addressing the full continuum of their needs. Of course, this is way too much for any one organization to do. It's really not in anyone's bandwidth or in their wheelhouse to be able to provide highly individualized services in addition to all the social determinants of health. So we really need networks, and it really takes a village. We need networks, we need partnerships in order to make the largest impact on patients. All right, so that's really what the cohort management program is doing. In addition to getting our partners ready and CCN ready for value-based payment. So the program has a planning phase, and in that planning phase, our partners are really planning how they are going to collaborate with other organizations in our area. So the partners convene a network, and that really could build on existing referral relationships or other partnerships, But we've really tasked our partners to expand beyond what they've already been used to. We're asking them to form at least one new partnership under the program. And with that network, the organizations are tasked with identifying some shared objectives and goals. When they do that, they're really building consensus around what their population cohort really looks like. So they're defining that cohort inclusion criteria and setting some specific goals for patient outcomes. This has really been a very collaborative process. It's really not one organization within that network that's setting goals or priorities. It's really been that shared objectives. Also together, the networks are tasked with identifying some core services and strategies that they are going to implement to then help their population cohort meet those goals. So the goals are around improved patient outcomes. And then, of course, in the planning phase, the networks have to address all the logistics that that we're really facing every day. So sharing data is obviously one big hurdle, and the logistics of flowing funds. So we've aligned this program with the VBP roadmap. We require the networks to have at least one Tier 1 CBO and address at least one social determinant. In addition to that, CCN is really just contracting with one organization in that network. So we have that value-based lead contractor that we work with directly. And that organization is then responsible to flow funds to the network partners in a way that recognizes level of effort and is equitable and has consensus. And then they're also tasked with making sure that the data sharing arrangements meet all the relevant laws. All right. So the program itself is designed to improve outcomes. The networks have to have alignment among a clinically high needs cohort, and we've defined it or required that they define that population to be aligned with our district goals. The network has to have specified goals for improved outcomes and some very specific core services and strategies to achieve those goals. We have 18 networks that are in either development or operation now. They're actually we have about 5 that are in active management, and the rest will be in active management by the end of April, I believe. And they really run the gamut. So we have partners or networks that are addressing behavioral health needs, addressing chronic conditions, gaps in primary care. Some networks have defined their cohort on the high ED utilizers and addressing a broad range of needs there. And then a few other kind of just niche cohorts. All right. So this is also this is a map of our service area. And I didn't mention this earlier, but Care Compass Network is located in Broome County, and that's one of our population centers. After that would be Tompkins County, where Ithaca, the city of Ithaca is. We kind of divide ourselves into a north, east, south, and west quadrant, and the south and the north have most of our attribution. The east and the west are kind of about 10% each. All right. So once the partners and the networks are in active management, two different things are happening. One is that the networks are convening and meeting on a regular basis to track their populations at an aggregate level. So in those activities, they're tracking service engagement. They're figuring out how to make the referral pathways between partners easier by integrating services. They're identifying gaps in care and creating action plans to address those gaps. They're working out the details of flowing funds. A lot of them are doing case conferencing on their cohort members to identify some specific needs among individual patients and figure out how that network together can address those needs. So using those activities really are part of a population health approach where we're tracking at the aggregate level and then figuring out individual strategies for individual patients that are aligned with those overall goals. The partners also are kind of actively managing the network in terms of managing kind of month-by-month funds flow between the partners, figuring out the logistics of data sharing, and then managing network resources. Along the way, we have the networks are kind of tasked with identifying whether or not their network, as it is today, is actually sufficient to meet the needs of their patients. So, do they need to bring in additional organizations into that network to help manage? And then, these are kind of all lead up into specific competencies that we feel like our partners need for VBP participation. So the skill of brokering partnerships and identifying common goals and objectives, and then the kind of day-to-day running of the networks. So just to kind of summarize it in a slightly different way, partners are tasked with bringing together an overall strategy for improving outcomes. So the core services that are going to help improve patient outcomes kind of fall into clinically oriented interventions, which are really things that partners are obviously doing today. So it's that SUD and mental health treatment and recovery services, it's disease management, it's primary care, peer support and care management in different forms. And then they're bringing in interventions on the social determinants of health. So we listed out our kind of top 5 social determinant interventions, so including services that support families and communities, navigation to primary care, developing patient self-management skills, and developing patient health literacy skills as well. Transportation is a big issue in our area because we're fairly rural. So we have a lot of different transportation programs going on that have been very effective in getting patients to where they need to go. And we really focus on, there's obviously medical transportation for medical care, but we've expanded out the transportation services in our area to include non-medical transportation. All right. So I thought it would be useful to kind of go through almost a thought experiment. We can just do this at your chair, but this is an activity that all of our networks had to do as they were defining what their goals were and what their approach would be to managing a cohort. So, the first question is, or the first task that you have to do is to think of a patient group that is really important to you. It could be a patient group that kind of keeps you up at night, or that a patient group that your organization might not really have a handle on their full health needs, or a group that is really critical to your overall success of your mission. So you maybe just, I don't know if anyone wants to shout out or raise your hand, a group that you're thinking of. Think about like the disrupt bread and butter. Diabetic schizophrenics. Okay, that is very specific. And great, because there is a disparate performance metric for that. Right. So she identified the group and she really described it using diagnostic terms. So our partners have thought about how they define their population cohort. A lot of it is on diagnostic criteria to start with. There's often a geographical component to it as well. So maybe it's diabetic schizophrenics in a county that you're from. It could be defined that way as well. All right. So we have partners under the program that are focusing on chronic conditions like diabetes, on high ED utilizers, maybe specifically at one emergency room, uncontrolled diabetics. Obviously, having uncontrolled diabetes is not great for anyone's health. Substance use disorders also an important focus. And so the networks are then tasked with, and you should do this as well, identifying some key needs of your priority cohort. So maybe you want to identify something that you know that diabetic schizophrenics have that might not be addressed today.
Medication management, proper testing, follow-up from their primary.
Right. So she said medication adherence, lab monitoring, and primary care follow-ups. So the question that you need to, if you're going to provide wrap a set of services around that population, what are the kind of key ways that you would do that? So you might, Right, you might provide health homes. So that's a care management program that is going to address the full range of needs. You might also need to address access to healthy foods for your diabetic population. There might be childcare needs that your population has that aren't being met today, that prevents them from using services as they should. Developing healthy behaviors and kind of coping skills. Identifying transportation needs, and sorry for the running over onto different lines, but also self-management skills. All right, so now think about if you're gonna meet all those goals, who do you need on your team to address those goals? So you probably can't do it all on your own. You're gonna need, you need that village. So you have to think about organizations that are well suited to address those specific needs, even if your population cohort is pretty small. So what you want to do is build your expanded care team. And that expanded care team is really your network that will help you under a future VBP arrangement. So you can start with your clinical team. You can perhaps add a community health worker or a care manager, depending on the organization. You can bring in partners that provide nutrition services or access to healthy foods, or just address another facet of food security. You might need to address housing services. And employment and vocational programs might also help you as well. So it kind of depends on your population of interest, who you need on your team. But the idea is that you're addressing the full range of individuals' needs, both clinical and social, within your network. And you're tracking your population against your goals to see how, where your gaps are and where your hurdles are, using kind of like a traditional continuous process improvement approach to addressing those barriers, and then kind of more seamlessly wrapping services around that patient. So at this point, I'm going to turn it over to Shelbi. Shelbi's going to go through a specific case study under our program and just share with you their experience in using this approach.
Hello. So as Emily mentioned, I'm Shelbi DuBord. Is this too loud? How about this? It's a little bit better. I come from the nonprofit world. I've been with CareCompass for about 1.5 years. And prior to that, I spent 4 years at United Way of Broome County, where I was responsible for a number of things, primarily convening groups of people together for various purposes, from recovering from disaster to healthy living, childhood obesity, and an anti-poverty reduction initiative. So I have a lot of experience in bringing together diverse groups of people, and that's kind of what I want to talk to you about today. So before I get into the case study, I'm just curious, show of hands, how many of you have been in a role either now or in your past career where you have had to convene stakeholders? Okay, all right, good majority of you, that's great. So I want you to be thinking about not only your current role that you're in, but any past roles that you've had where you've had to convene stakeholders as we go through this, and just see if this applies for you. So I'm going to talk to you about our Lourdes Hospital Opioid Use Disorder Cohort. So as Emily mentioned, we have 5 health systems in our PPS. Lourdes is one of those 5 health systems. They're located in Broome County, and they also serve Tioga County. And they were one of our first networks to come forward and throw their ring in the hat for this pilot project. And they said they want to work on opioid use disorder. So what they did is they identified their cohort, the inclusion criteria. So the inclusion criteria is, it's not really listed here, but it's basically any individual with an opioid use disorder living in Broome County. And there's 3 ways. Let's see if I can get the laser to go here. There's 3 kind of tracks that they can find these people. So they can find them through a needle exchange program, through the hospital, either ED, inpatient, or walk-in, or discharge from the detox. And they can find them from being disengaged from treatment, meaning they were in a treatment program, but they are no longer engaged. And this is just kind of the theoretical model. I'll talk a little bit more in depth about it. But what they're doing is they're using a community health worker. which is from a CBO in their network. And they're conducting a health needs assessment. So once they find these patients, they're going to ask them if they're interested in conducting a survey or participating in a survey. And our survey is a blend of the Prepare tool as well as clinical needs assessment to kind of give them a risk score, not really risk score, but just a score of how high are their needs. And based on that needs assessment, they're going to create a plan that addresses their social determinants of health, their addiction treatment, and their medical care, and they're going to wrap services around those patients. And this is a little bit more information than you guys probably need, but as we have designed this program, we've asked the networks to say, when would a patient graduate? You know, if you're working with them for 6 months and they seem stable, do you stop working with them? Do you stop having your services wrapped around them and you kind of like set them free? Or are you going to continue to work with them? And Lourdes has chosen to continue working with them unless the patient passes away for some reason. So they're just going to continue to wrap services around these patients. So the partners in the network, we've required a minimum of 3 additional partners, so a total of 4 partners in every single network. Lourdes decided to go for the gold, and they have 6. And so we've got Lourdes. They're the value-based lead contractor. We have Reach Medical. Has anyone heard of Reach Medical? No, they're kind of growing, and I know they've done a lot of presentations in the Albany area, so I wasn't sure. Reach Medical is really cool. They're a medical provider that's focusing on harm reduction, and they're getting some national news lately. The Rural Health Network of South Central New York is a large, I don't know how many counties, I'd say at least 8 or 9 counties in our region that provides community health workers, they provide transportation. They have an innovative program called the Fruit and Veggie Prescription Program where they are actually providing vouchers to individuals who have a health need to get fresh fruits and veggies. And then we have the Addiction Center, Broome County, which is a substance use recovery center licensed by Oasis. Truth Farm, which is a Tier 1 CBO, they are more of a peer recovery model of substance use recovery. And then the Southern Tier AIDS program, they serve as kind of a care coordinator, care management agency. So these, and I want to just note that these 6 partners didn't all have pre-existing relationships. Some of them were already working together, others were pulled in. So as they were designing the cohort and they knew they wanted to work with these patients, they started thinking who else would be good to invite in. And there was a lot of back and forth discussion. They had the planning phase really lasts about 4 to 5 months at least, and we've really kind of been rushing them and keeping them on pace. So I think it could, if we just let it go, it would naturally take even longer than that to build those relationships. And so the funds flow, what Emily already mentioned is that in the process of planning, we're asking them to say, how much are you going to pass down to your network partners? We're going to give you this much money to do the services for your patients. How much of that are you going to give to your partners? So it's a little bit of a dance for the network partners to say, here's how much I need, how much are you willing to give me? And they all have to collectively agree on that funds flow model. And all of our 18 networks have done it a little bit differently. There's really no one way that they're all choosing to do it. We're giving them that freedom. So what Lourdes has decided to do is for the needs assessment, which is we're paying them a flat fee for that, for every single needs assessment that's completed. They're going to pass that through to the partner that completes that. It's pretty simple. The PM, it's a little bit more nuanced based on the level of the needs for that patient. So we give them either a 1, 2, or 3 score based on what how they've answered that needs assessment. And based on the level, they get more or less of a PM. And so they've decided that they're going to pay the partner who performs the care plan that full PM. The social determinants of health interventions, so we have a separate bucket of funds that we're allowing every network to tap into to address social determinants of health, and it has to be approved through our clinical governance committee. So the dollars that have been pre-approved through our clinical governance committee are going to be passed through to the partner that's providing the service. So an example from Lourdes for their social determinants is they're going to be providing childcare, they're going to be providing transportation, they'll be doing housing assistance if that's something that's needed, nutritional support, and then just kind of unmet needs. So they'll work with the patients and see if there's any other individual needs that they have and make sure that they're met. And then the performance incentive, so after the program is done, it's a 1-year pilot, we're going to look at their metrics that they've decided to focus on, and in this case, they're focusing on ED utilization. So we're going to look at the patients and see where were they at baseline and where are they now. And based on that improvement score, we're going to give them a percentage of their overall contract value. So they've decided they're going to split that equally amongst the partners. Other of our networks have decided to give more to the organizations that are doing more of the care plan and more of the direct client-facing services. So like I said, it's really across the board how they've chosen to do that. And what we're excited to learn is, are there any best practices in all of these, in the funds flow that we can share after the program is over? So goals and performance, we've asked all of the networks to define what they want to accomplish with their program. So I'm not going to read you all of these, but a few of their goals are to obviously lower ED visits, lower hospitalizations. I think it's really interesting. They're also focusing on educating the community and providers about how to engage the target population. They're kind of the leaders in our community as far as engaging with the opioid use population, and so their secondary goal is to educate the community about how to best engage, as well as to reduce the stigma associated with this population and provide, increase the number of providers who have the DEA-X license. And then data sharing. So we came in a little late in the panel session, but I did catch part of the conversation about data sharing. How many of you are currently kind of grappling with the issue of data sharing? Okay, all right, wow. So we are certainly not the experts, but we have asked the networks to define how they're going to share data during this program, and one of the supports that we provided for them is what we call our SFTP secure site. So we have a site set up that we've had for the past 5 years for our partners that we're allowing access to for them to securely upload their data on a monthly basis in order to get paid. And we're providing access to the entire network as long as that they have a partner agreement with us and a BAA. So that's one thing that a lot of the networks are taking advantage of. Others prefer to do it in their own way, and that's okay. They also have a data sharing consent form. So this is the consent form that every patient in the cohort is going to have to sign, and it's going to list all of those 6 partners on that form. That will allow them to share the data between themselves during their monthly, or I think it's weekly, case conferencing that they're going to be doing. And then Lourdes has established a business associate agreement between themselves and each of their 5 partners. And then they're going to be having monthly data stakeholders meetings where they'll be sharing additional data from not just the reports, but other things they've collected about those patients. Any questions so far? Yes?
What if the patient doesn't want to sign consent?
Then they wouldn't be a part of the cohort. Yeah, it's an opt-in. The hope is that they would. But they would just continue to look for patients until they have a full panel. And I can't remember if Emily mentioned it, but our size is we're looking at a minimum of 50 patients and a maximum of 200 for this pilot to be able to manage it, have it be manageable, and still harness some learnings to maybe scale that up at the end of the 1-year pilot. Okay. So that's it for the Lourdes example. I'm going to touch now on just some broader lessons that we have learned in launching this program. So the first thing is that the act of partnering is an art and a science. Now, many of you raised your hands when I asked about have you been a convener before. I'm sure you can all kind of acknowledge that it's not necessarily as intuitive as we might think it might be. There are people I've spoken with who think it's as simple as inviting the right people to the table and they're just going to get along. That's not always the case. So I definitely want to touch on this. One thing I don't think we mentioned yet was that we have assigned a team of what we call network facilitators to our networks. So all of our 18 networks have a designated staff person from our organization, from Care Compass, acting as a network facilitator. And this person is really in the role of supporting the network, not necessarily the note taker or the minute taker, but the support to kind of coach them In some ways, they're the mediator. In other ways, they're the teacher, the educator. They play a lot of different roles, and they wear many different hats, and we found this to be very effective. So in the concept of partnering and then this concept of partnership brokering, which really we're doing, we're brokering these agencies to be able to work together more effectively. There's this continuum, and we can't take credit for this. This is from the Partnership Brokers Association. If anybody's interested, you can look them up. But what this model kind of explains is that over here we have more transactional relationships. That's kind of where we all are right now, just naturally. We're in fee-for-service, so we're focused on service delivery. We're subcontracting our work, more of a funder-fundee kind of relationship. And we're looking to get towards this side of partnership, so mutual responsibilities, more complex relationships, and sharing the risk. And so how do we do that? We're focusing on deepening those relationships, helping to mediate differences so that partners don't walk away from the table when differences come up. And there are times where that has happened, where we have stepped in to kind of assist them. I won't, without sharing names of organizations, we have 2 providers in a network who are very similar, providing similar services. And they have been having issues where one of them says, we were the first to do this peer recovery service, and then the other one says, no, we were the first to do this peer recovery service in the community. And that's been causing a lot of tension. So we're stepping in to try to open that dialogue, kind of smooth things over and allow them to go forward so that nobody walks away from the partnership, because they're very important. All right. So I like this graphic because it really, to me, depicts the fact that partnership is more than just a science of just throwing people together in a room and expecting everything to work out. Because you've got people who are, if they're thinking about partnership, he's thinking about this, chart up here. She's thinking about sitting in a circle, singing Kumbaya. And everybody has a different thought process to what's going to happen when we come together. Is it going to be one person taking notes and everybody just listens to the facilitator, or when do I get to talk? What are my priorities and my goals? So the process of collaboration is really intentional, and we've tried to be really intentional about it. We're actually providing a training for our staff to go through this summer, where they're going to learn more about this art of collaboration management. So on the left side, the art or more intuitive side of it is providing insights. It's the reflective practice, and it's the active listening, the people skills, kind of more of the soft skills. And then the science is, the things that a lot of us have already, which is the good facilitation, note-taking, administrative skills, precise speaking, and things like that. Okay, and the second lesson that we've learned is that this is, in a lot of cases, this is going to require a lot of organizational adjustments, and that's also true from our own organizational standpoint. We've juggled lots of different roles. The role that I'm in is I'm kind of a trainer of the network facilitators, but I also have another job that was my job that I was hired for, and I was kind of asked to take on this additional role. So we're all wearing many different hats. And it's true for our partners as well. As they're shifting into this pilot program and into value-based payment, they're having to stretch themselves, change their mindsets and their behaviors, and I think in a lot of senses, shifting their organizational cultures, and that doesn't happen overnight. So we're trying to acknowledge that and bring light to that, so that it's not as painful for them. And then our last lesson is that what we're trying to do is really create a business case for these networks so that they can sell themselves to an MCO. That is what would happen in an ideal world, is that we can say, look at what we've done as a network and look at the costs that we've saved and that the outcomes that we've achieved through these social determinants. Like, maybe we'll find out that if providing childcare to the opioid use disorder population is the missing link, and that the investment that we've made has monumental returns. We don't know. It's all a hypothesis and it's all a testing ground. But we are working to measure the social determinants of health to get that ROI. And Emily and her team have done an amazing job of creating the systems to be able to collect the social determinants of health, the metrics, the goals, and all of the data to be able to paint that picture over time. So we don't have any findings yet, but maybe we'll be back in a year to share more with you. And then a little bit more about this, the social determinants of health are so important, but I think it's really hard to wrap our arms around that right now. We're kind of in a time where we all are acknowledging it's important, but we don't really know how to measure it. We don't even know how to put a dollar amount to childcare. One childcare provider is $20 an hour, another is $12 an hour, another is $30 an hour. So what's like a good price to pay for childcare? Same thing for transportation, although that one's a little bit more figured out. But this is kind of a new landscape that we're learning, and so we're kind of tweaking as we go and learning as we go. Okay, I think that's it. How are we on time? Time for questions and answers? Okay, so I think I'll open it up just to both presentations for questions and answers now.
Thanks. I have two questions. The first one is for Bob. The level 1 that you're preparing at Beacon, is it with one health plan or more than one?
When we, so we have 9, you might know, we have, I believe, 9 or 10 plans in New York that we partner with. So generally what happens is, in almost all cases, we contract with the providers and we run the network. So when we contract with the provider, the contract essentially says it's for all of our health plans. Now, 90% of the time they all go along with it. Occasionally one may not, but generally it's for all of them.
Thanks. And my second question is for Shelbi or Emily. That 1-year pilot, does it include those 4 to 6 months of partners needs assessment, or is that outside the 1-year pilot? Because you said it takes a long time to get the partners to sort of come together, and you have to keep them motivating to get going. So is that outside that 1-year period or inside that?
So the active management is meant to be a year, and that's where the partners are tasked with a kind of live set of members that they're managing. And they've already, at that point, completed all the planning that they needed to do to kind of launch their plans. The needs assessment is something that we're using to identify how much we should pay the network for each specific member. So they do a needs assessment, and they get a score, and then that score correlates to a level, and the level determines the per member per month payment.
So thanks for that feedback. So for CBOs sitting in the room, what you're saying could take 2 years.
I would say that thus far, our networks have planned for, I would say 4 months.
Yeah.
Kind of an average of 4 months, and then our program will run through the end of district at a minimum.
So about a year and a half, I think, is our timeline. It is rather condensed. I think if you're going to design a program like this, I would give it 2 years if you have the time. Mm-hmm.
For the Lord's pilot, did you have an idea administratively the cost of, it sounds like a lot of foundation building in the beginning. Obviously, as it grows, you don't have to replicate that. But do you have an idea of a percentage how much at the network level and then the providers level, how much you had to fund for administrative costs?
So are you asking about what Lords themselves are investing or what we're paying?
Well, what you were allocating from district funding?
Okay.
So we decided to take the approach of we'll pay our partners to plan, and initially we allocated $50,000 per network to plan, and we had kind of an early sign-on bonus of 25. So if they did everything by, and I think all of them did.
Then we increased it to 100,000.
Yeah, then we had another. So more planning funds. So per network, we reimbursed at $100,000 for the network. So not just one individual, but for the network. And it was up to the network to decide how they would distribute even those funds to the partners.
That was
Yep, right. That's where the VLC plays that role to distribute funds.
Maybe deadlines and certain guidelines or milestones.
Right.
Reward that performance.
Yeah, it's basically like a planning grant. We give them $100,000 and they have 3 milestones to complete to say, you're done, you're ready to go on to active management.
Thank you.
Does
Any other
anyone want to
questions?
ask about double dipping? Okay, we'll answer that question. So this was the issue of double dipping and paying for services that are paid for either through the Medicaid program or another source was an issue raised in the beginning of our design, and we pay a lot of specific attention to that. CCN as a PPS is at risk, bears that risk, as well as our partners. So we've identified that that our network funding, so that per member per month funding, goes to our networks for network activities. All of those partners are providing services to patients directly that are probably being reimbursed. Where they're not being reimbursed, then CCN has other funds that can reimburse those services. For example, non-medical transportation is not something that's typically reimbursed under the Medicaid program. So we have funds for things like that. We have other, what we call them unfunded services, like the kind of disrupt example of providing air conditioners to people with COPD to improve their outcomes. There's probably not a source of funding for air conditioners under the Medicaid program, so we're providing that kind of gap funding. But there's a specific review for whether or not a funding source exists out there today.
So this is a great program, from my opinion.
Thank you.
How do the
Tell Donna.
benefits stay limited to just a Medicaid patient and not spill over to other patients with commercial or Medicare or uninsured?
Two ways. That was an opportunity that some partners raised in the beginning of they wanted to identify a cohort and include non-Medicaid members. But we kind of ruled it out in the beginning to say that CCN funds were not going to be used to pay for those services. And the way that we do that is we're kind of utilizing our process of data reporting that we've used for the projects for this as well. So we require the networks to submit a patient roster, patient list every month if they want that per member payment. And they're providing us the SINs and other identifiers that they have been doing all along under the district projects. And then we're also paying for either the needs assessment or those unfunded services, kind of in the same way that we're paying for navigation services under the navigation program. So we're utilizing the tools of DISRIP for this other thing.
I actually have a question. It's about the collaboration training that was mentioned. I'm curious what that looks like. Is that something that was created internally, or are you using an outside source for?
Mm-hmm. Yep, we are using the Partnership Broker Association to come on site. It's an association that provides global training, so you can search for Partnership Brokers Association. I think it's maybe .org. They were founded in about 2012, so they're relatively new. They're based in the UK, but they do operate globally. It's a 4-day intensive in-person training that right now is just open to our internal staff and a few of our partners. But I went to the training myself, kind of like scoping it out last year, found it to be so immensely valuable that we decided to bring it on site this year. So you can do a commission training at your location, or you can send somebody. I think the closest location would be Washington, D.C. They do that annually.
Thank you.
Go ahead.
This question is for the first presenter too. So at Beacon, you said you want to be sure that the data is correct, so you use your own claims. And so how do you ensure that your providers are submitting the correct codes for the claims? And like, is there measures that you take to help train or enhance that?
Yeah, we have measures for all that. So we go through, we have metrics where you can evaluate the accuracy of the codes that they're put on the claims. So we do that deeper level dive to see if they're actually submitting them correctly.
Thank you.
It's a question for CCN. I'm just curious what role, if any, the health home played in the work that you guys were doing.
This was also, how we bring in the health home was also part of our initial design, and we had a strategy around that. So we actually, I don't believe we have a health home as a partner today. They certainly could be a partner, and that kind of invites almost potentially more double dipping issues because care management is part of some of the unfunded services that we're providing funding for, and obviously health homes provide care management. So they could operate as a network partner. We just wouldn't pay for anything that would be included in the health home service package, I guess.
Yeah, I had to rack my brain a little bit to remember all of our networks, but I think there's 2 or 3 that they're a referral source. So the network has decided we're going to refer our patients to health home, kind of almost as a screening tool. And if they are eligible for health home, then they kind of go out of the cohort, they go to health home. If they're not eligible, they would work with them.
So I'm just curious, like when you're trying to figure out the shared savings and who to give the incentives to, what your logic was in terms of dividing it by 6. I mean, obviously that's an equal share for everybody, but obviously there's different levels of participation probably in terms of what gets the member or the patient to the end goal. So I'm just curious about what your thought process was when you made that determination.
That's a great question. So first of all, that wasn't my determination, that was theirs. They chose to do that. But they have decided, since all 6 of those partners are required to be at their monthly case conferencing, and actually I think they're doing more frequent case conferencing than that they would share in the savings, because we're paying for the case conferencing, the coordination of the coordination, as Emily said. We're not paying for the direct services, so we know that there might be heavier lifts from some partners than others, but we're not paying for that. We're paying for them to get together to make sure that there's no gaps and that the care is really tightened up. So it really is an equal share, I think, at least in the LORS network.
This is a question for Bob. Those level 1 contracts with the 9 MCOs that you're working towards, are those 1-year contracts or longer than 1 year?
They're 1 year, and then there's a clause in there that says after the first year, we reassess it. So they're 1 year, they extend, but then we got to go through, because what happens is you've got to set up the metrics, the baseline metrics. So each year we're going to go through and redo the baseline metrics. So I mean, it could happen that, at the end of the first year, depending on how they performed, we come up with the metrics and they say they don't want to do it for the second year. That's possible. So it's an each year thing.
And do you think that the metrics will be the same for all 9 plans?
No. They're by provider. They're by provider, not the plan.
Oh, right.
Yeah.
And then one thing about sharing your claims data, which is part of my workflow.
We share reports.
Do you have claims?
We do reports.
Do you have claims lag? Like, how far back can you share with
Yeah,
a partner
our
your
claims, it's generally a 90-day run through. So what we'll do is we'll do a look back 90 days after. So it lags a quarter.
Emily, I have just a question. You mentioned non-medical transportation solutions that some of the network partners have come up with, or the networks, I should say. Can you elaborate on one of those?
This is actually one of CCN's, I would say, kind of best practices from almost like DISRP Year 1. We have an innovation program, and one of our CBO partners, actually it's the Rural Health Network of South Central New York, they're one of the MAS contractors to the state. So they provide transportation services to Medicaid members, to start with. And they came up with a voucher program called Get There that we've actually replicated in other parts of the PPS. But Get There is specifically to provide the same kind of transportation support for health-related needs that kind of go beyond what MAS pays for. So that would be the non-medical component. And they use vouchers. They have a network of transportation providers. So some of it could just be bus passes and things like that. But they have administered that program, and we've kind of replicated that model in other parts of the PPS.
Does that include like grocery shopping, pharmacy,
Yep. Right.
like AA, stuff like that?
All of that, and even like community classes, things that would enrich their life, kind of be a part of their care plan.
What is the method of saying this person is able to utilize? Is there like an intake, or where do they go to utilize it?
I think they receive, so the Rural Health Network works with local medical providers, offices, and they give them a set of vouchers that they then share with Medicaid members. Actually, I think that's for everyone.
Certain providers, but Medicaid, yeah, Medicaid providers.
Only Medicaid?
So.
Okay. So they share the vouchers with the patient, and then the patient then works with Rural Health to schedule a ride, and then it's paid for under the program.
Great, thank you. And Bob, you talked earlier in your presentation about appropriate attribution and how it's kind of evening out now that the BHCCs are more of an entity.
Yeah.
We also know that there are a lot of nonprofit organizations that maybe don't bill Medicaid, but also help that population in terms of social determinants of health.
Right.
So how do you decide attribution, or what's some advice you can give to those entities to build their value-based
The only thing I
model?
can think of right now is, again, because everything we do is based off our claims, so somehow they're going to need to partner or combine or link to somebody who actually submits claims payments, right? So they may, partner with them and provide that piece of it. And if we can actually, anything that we can measure and count, we'll potentially do a contract with somebody. So if they're linked with somebody and we can attribute what they do to that population, then we could potentially come up with an arrangement. That might happen. Yeah.
Thank you. Are there any other questions?